Not every barrier to care is obvious at the bedside. Sometimes it shows up as a delayed follow-up appointment, a medication the patient can't afford, a lack of transportation, a language barrier, a policy that seems neutral but doesn't impact everyone equally. That is structural bias. It's not just about individual decisions, it's about the systems that shape who gets access, who gets believed, and who gets the benefit of the doubt. Hi, I'm Dr. Ryan McLoughlin, and in this episode of Teach Me Something New, in under 5 minutes, I'll walk you through how structural bias shows up in real time and what we can do to recognize it before it affects patient care. What's the problem? Systems aren't neutral. They're built with processes, protocols, resource limitations, and those can unintentionally create disparities. The clinical reality: two patients with the same condition can have completely different outcomes based on how the system interacts with them. So what is structural bias? Let's define it simply. Structural biases are system-level factors that create unequal care. This isn't about individual intent. It's about how care is designed and delivered. Examples in the emergency department: delayed interpreter access, differences in triage pathways, lack of standardized protocols, and variance in resource allocation. And the result? Missed or delayed diagnoses, treatment disparities, and reduced access to care. The key idea here is you can do everything right clinically, and the system can still fail the patient. Why does this matter? This is where it becomes high stakes. Structural bias drives health disparities, variation in care, and loss of patient trust. And in the emergency department, we are the front door, and we see the consequences first. The clinical translation here is, if the system isn't designed for equity, outcomes won't be equal. Let's talk about a framework for how to respond in real time. You can't fix the entire system on a shift, but you can recognize it and respond. Think of this as a 3-part approach. Step 1, spot the friction and ask yourself, is something delaying care? Is communication a barrier? Is the patient getting less access than they should? Common triggers to clue you into the friction spots are language barriers, social complexity, and atypical presentations. Step 2, close the gap. Take immediate action. Call for an interpreter early. Use standardized pathways when available, and escalate other hospital and community resources when something feels off. Small actions can make a big impact. Step 3, standardize where you can. Lean on protocols, checklists, objective pathways, because standardization reduces variability, and variability is where the bias lives. Bonus: think beyond the shift. After the case, ask, could the system work better? Is there a recurring gap? Who are the community stakeholders and decision makers? That's how change starts. Now, let's talk about real emergency department application. This is what it looks like in practice. A patient comes in with limited English proficiency. Without an interpreter, the history is incomplete. The workup is delayed, but you recognize it early. You call for an interpreter immediately. You ensure understanding before disposition. Same patient, different outcome. That's structural bias interrupted. So to wrap it up, 3 key takeaways. Structural bias is built into systems, not individuals. It shows up as barriers, delays, and variability. And small, intentional actions can reduce its impact, adding up to many small impacts that bring about system change. A final word: great emergency physicians don't just treat disease, they recognize when the system is part of the problem and step in to fix it.